Thank you very much, professional psychologist Alejandro Ibarra, for joining with to talk a little bit more about OCD, to continue the conversation we had last week about how OCD is impacting everyday life. Today we're going to specialize in the Ibarra exchange. We're going to focus and specialize on Zoloft and antidepressants, how they have worked or not in OCD. And also, we're going to touch a little bit about the reality of cognitive behavioral therapy, especially one that you do, the ERP. Thank you very much for joining me again. I appreciate it.
Thank you, Luigi, for having me. And to me, it's a pleasure to be here with you and with all the OCD community that is watching this video. And to me, it's a big opportunity to talk with you about OCD and about medication in this moment.
Last week, we found out that what you do. Now I want to actually understand even more about the specifics of what you do. You're a licensed trained psychologist in OCD. You do cognitive behavioral therapy. Now, you have a patient, they come, he or she has just seen a psychiatrist, taking a medication that may or may not work, have seen a previous psychologist, okay, that didn't really know much about OCD. You're the expert, okay? What is the first technique you use and how do you help them?
Yes, the first technique we use in CBT, in cognitive behavioral therapy, the name is ERP, exposure with response prevention. ERP is the gold standard treatment to treat the OCD symptoms in all the world. So ERP basically consists in face your fear. Exposure is face your fear or face your obsessions, your thoughts. After that, you have to create a habituation in the anxiety, this anxiety high. After that, take a middle level and slow down. And the person...
But when you say face your fear, sorry for interrupting you, Aran, it gets very controversial when you have a conversation of pharmaceuticals or cognitive behavioral therapy. But when you say face your fears, I will imagine it's more people that suffering from phobia and panic disorders, and actually they're scared of like elevators or spiders. You know, how can someone with OCD face their fears if their actual fears are the things that they hate, are the things that they're causing them problems?
Yes, a good question, because the way is face your fears through your thought, through your mind. You have to close your eyes around 30 minutes and you have to face your fear. Depends on your thoughts. Imagine that the thought is, what if I don't love my partner, for example? So you have to exposure to that thought around 30 minutes, and after that you can not do the compulsions, do the ritual. Rituals maybe could be mental or motors or physical ritual. So this process is ERP, exposure and response prevention. Response prevention is not to do the compulsions, and it's going to add in your thoughts. It's going to do the change in your brain, change in your behavioral, in your thoughts, in the way that you react with your thoughts. It's changed. ERP is a challenge. So it's the main treatment in OCD. It's a gold standard treatment.
It sounds a little bit more like meditation, and when we're talking about OCD, the obsession, the compulsion, like the thought and the action, you're saying we have to get to the thoughts. We have to get to the cognitive part. We have to disrupt the intrusive thoughts. We have to disrupt what's already being disrupted, and that's the point. So they're not physically exposing to their fears, like in the case of someone suffering from a panic disorder or a phobia. They're mentally sort of like reanalyzing and reevaluating and sort of like making their fears a reality. When you say face their fears, they're asked, you know, why are you be so scared of?
Yes, the first step is through the imagine, through your thoughts. After that, you can do the exposure response prevention in life. okay? In life, maybe in the street, or maybe in your house, or maybe in your office, or maybe in a park. Why? Because depends of the thematic, of the theme, of the kind, of the subset of OCD. In OCD of contamination, you have to do a part of your treatment by the imaginal thought or imaginal exposure, and after that you have to go to the street, you have to go out there to put it on the exposure and response prevention in life. Why? Because some triggers, the triggers are not in your home or are not in your office, maybe are in the street. Triggers are everywhere. So after do the exposure in imaginal, you can, or you have to do the exposure in life. That is the second part, okay? So definitely is the gold standard treatment, and the combination between exposure and imaginal and exposure response prevention in life, it's going to be the change in your brain to do the control your compulsions and control your symptoms.
Which is why it will last, sorry.
No, until your symptoms are get out of your life, okay?
Or you improve a little bit more, there's a little bit less impairment. When you say you do it first for 30 minutes on a typical standard first patient, how many times during the week do you repeat ERP in session with them?
Depends of the several of the symptoms. In low OCD or level down, level not very high, you can do the exposure once a week.
My OCD, mild to moderate,
exactly.
as opposed
exactly.
to moderate to severe.
Exactly.
And there's a biological reason why it would be 30 minutes and why it would be many times a week, depending on the severity. You're trying to change the neurotransmitters. You're trying to change the cortical system through therapy of the brains. Now, my question to you is, my set of questions, let's call it, do patients come to you already on medications with Zoloft or their antidepressant? 2, if they do you tell them, stop taking them, detox, you want your cognitive therapy to work? 3, if they have like the quite opposite, they have a severe OCD, not mild, not moderate, severe, ranging and comorbid with other some sort of anxiety, depression, even psychotic, okay? Do you tell them to go to the psychiatrist? 4, do you keep in communication with psychiatrists, especially for a specific type of patient? And then 5, are there psychiatrists that are also, at least in Spain or the European Union, that are specializing OCD the way you as a psychologist are specializing OCD?
Yes, when the patients come to our practice office, the first step is continue the medication. If the person suffer with several symptoms, they need medication, and we are specialized in psychologists and CBT and ERP. I'm not a psychiatrist, so the thing is that the doctor continue the medication. So if the person of the sufferer come with me to my practice office with low or with middle symptoms, my recommendation is not to take some pills or not to take medication. Depends on the person, of the case, of the evolution of the disorder, the comorbidity with other disorders, the age of the person, the age of the patient, the kind of the subset of the OCD symptoms. Depends on many things, no, many topics. We recommend medication in several symptoms, and it's very important because we have to combine the medication with ERP, because both potentially the treatment. So it's the best way to control the symptoms. But if the person come to our practice office with no medication, my recommendation is no medication. Why? Because the secondary effects that has the medication, we all know some effects of the medication. You as neuroscience, you know all the symptoms or the effects secondary in this kind of medication, in antidepressant, for example.
Yeah, it is important for the viewers to understand that even though obsessive compulsive disorder used to be in the DSM-5 as an anxiety disorder, now it's its own obsessive stress-related disorder, but it is pretty much within a bigger umbrella of anxiety and stress, as opposed to moody, depressive, bipolar emotional disorders. However, the particular thing about OCD is that it gets so drastic that the rituals, the compulsions, they impair so much in people's life that medical doctors, as tend to happen, they found that a drug that used to help for something else, such as depression and bipolar and dysthymia and affective disorders, now can help an anxiety disorder, a stress-related disorder like it is OCD. However, there's a catch, okay? It's not the same quantities that it will work on people that have major depressive disorder. Okay, we're not talking about 50 milligrams, we're talking about 200 milligrams. And the patient cannot... Exactly.
Normally, the medication is at least four times up to the depression, for example. If to depression is 50 milligrams, to OCD is 4 times up at least. So it's a very high dose.
And it's not like the patient can just start taking 200 milligrams of Zoloft right away on a Tuesday. They have to slowly increase and gradually, which it could be a little bit disappointing at the beginning because they're not going to see the effects that it happens. So it has sort of like the worst of both worlds. You get the same medication that people with the depression have at higher doses, and you still have to wait, just like in depression, you still have to wait 2 weeks to see some effects. Now, in the case of depression, it takes 2 weeks because in Zoloft and these antidepressants, the neurotransmitter, the chemical that it's working in the communication between the neurons, this chemical that actually causes the electrical communication, okay, which we call serotonin, it's very widespread all over the brain. There's a lot of circuits, there's a lot of wires that go from cortical to the subcortex where dopamine exists and dopamine is working. However, in OCD, it takes longer to work because you have to get to the right doses to actually try to make a change. So it could be very, very frustrating for a patient with OCD, start taking Zoloft, wait for 2 weeks, every single day, increase the doses and wondering why this is not working. My psychiatrist is horrible, the medication is horrible, but the reality is like the neurotransmitter that is supposed to work takes its time, it's all over the brain, and it overlaps and intersects with a lot of circuits that are related with emotion, with pain, with sexual activities, with appetite, with fatigue. So there could be the chance, like I can't understand how impairment can it be, because there's a chance that Zoloft and these antidepressants not only don't help you right away, but they, at the beginning, can feel that it's giving you even more problems. So what would you say to those patients that are not seeing a psychologist yet, but are seeing a psychiatrist, they're taking Zoloft, and it's not working at the beginning?
Yes, I always recommend visit the psychiatrist to control the medication. If the person is taking Zoloft and not I'm a psychologist specialized in CBT and ERP, no doctors. So my recommendation is visit the doctor. So in many cases, in many patients, Zoloft is not the best choice, or antidepressant is not the best choice. We work with gold standard treatment with ERP. So versus medication, the ERP is around 75 or 80% of the results of the control of the symptoms, and 20% is the medication. So every day we recommend do ERP, do exposure with response prevention, change your mind. This is like go to the gym. This is a work. The ERP is wonderful because works, but it's work. You have to do the work. You have to exposure. You have to face your fears. You have to control the compulsions. You have to to be the consistency to do ERP every day, or at least visit your psychologist once or twice a week, at least. So it's going to progressive, take time to control the symptoms and to control the OCD. But it's very important because ERP is the present and the future in the treatment in OCD, okay?
ERP is a present in the future in OCD, but just to emphasize and to summarize, sort of recap, people don't have to detox, don't have to abandon the medications with Zoloft to start an ERP. They don't have to give up. They can even start working with a psychologist and then at the same time or later work with a psychiatrist and get Zoloft or any other antidepressant that actually works that actually changes the serotonin levels. And I think that in a way that's even when we talk about nature versus nurture, that's actually the best way of treating these disorders, doing cognitive behavioral therapy with biological therapy. Why? Because cognitive behavioral therapy, it's not just you're changing just the way people think and act. You're actually, in a way, targeting the neurotransmitter. You're strengthening the communication, the chemicals between these neurons, and changing the way the cortical circuits work. It's not as fast and it's not as direct as a medication would, and it's definitely not like other treatments like transcranial magnetic stimulation or deep brain stimulation, where you're actually inserting electricity or magnetism to change drastically the neurons. But you, as a psychologist, you are conscious that with this therapy, you are trying to reactivate the level, the circuits in this person's brain. And what's even more interesting is that in a way, you're maximizing the potential that Zoloft or any other antidepressants have. You're actually making it stronger. Okay, you're actually complementing Zoloft. If Zoloft wasn't working before, because it didn't reach the threshold, now they're reaching it with your therapy.
Antidepressant is just a little bit part of the treatment. Because remember, and don't forget that OCD is a cognitive and behavioral problem, okay? Because the person cannot stop the compulsions, and it's behavioral. And some part in another way is in the brain. But you have to do the change with the compulsions. You have to do the change with your behavioral. And it's the everyday that is not with medication, because medication sometimes reduce a percent of the intensity of the compulsions. But the main treatment and the main goal is with the ERP, is every day, like going to the gym. It's exactly the same. Because remember that the brain is a muscles. It's like train your muscles.
Yeah, plasticity. There's plasticity when you take the medication. There's plasticity when you do the therapy. Let me touch upon a little bit. Maybe I misheard you. You're saying that the ERP works more with the intrusive thoughts, works more with the cognitive part of OCD, while the medications attack more the behaviors, the compulsions, the rituals. Did I understood clearly? Is that what you're saying?
Yes, medication can work with a little bit in some of the thoughts, some of the obsessions, and some of the compulsions. Why ERP works? Because the thoughts depends on the triggers. Remember that the triggers maybe could be a bottle of water. So if I think that it's not easy and it's contaminated, and I'm going to take a really disease, for example, that is not with a thought, that is a compulsion, because after that I have to take and wash my hands 40 times or 50 times. It's not my thought that what if I take a bottle of water and contaminate
before the pandemic, wash your hand 40, 50 times even before the pandemic. I see. So you're saying there's something about the triggers that we haven't touched, but we're definitely gonna continue talking in the next conversations. You're saying that the triggers, when in Spanish they call desencadenante, these triggers, okay, are the reason why these rituals start. So what you're trying to do with the ERP, among other things, not only, you know, improve the well-being and reduce the rituals, but reduce the reactiveness that the patients have to respond to the triggers, to be triggered by the, yeah.
Exactly. ERP help to you to change the behavior, to not do the compulsion. That is the big problem in OCD. It's not just the thought. It's not just the what if I turn gay? What if I don't really love my loved one? What if I'm a murderer? Or what if I kill someone? It's not just the thought. It's the compulsions. The way that you react with your thoughts, that is the big problem. And the way that you change is with ERP.
So, okay, let's switch gears a little bit. When you talk about bipolar disorder, people think that you absolutely should have a manic episode and a depressed episode. Actually, that's not true. Once you have a manic episode, you are diagnosed with bipolar disorder, okay? You don't need to actually reach the 2 poles to get the diagnosis, because there's no other diagnosis that you can get once you get the manic episode. In the case of OCD, the people that have the intrusive thoughts that impair hours of their lives, and like you said, they're thinking about using a knife, they're thinking about, I don't want to overlapping with psychotic features of, or depressive or suicide, but you know, let's continue with the washing hands, the bottle example, the turning on and turning off the lights, the completely checking the time, the quantity, the temperature, you know, if they go to work out, the routine.
Exactly. Ritual of repetitive rituals.
What if the person only has, just like in bipolar disorder, only has the intrusive thoughts, but they never materialize into compulsions? Would that person still get a diagnosis with OCD?
Never. The person with OCD never just do the compulsions, but never do the thoughts. Why? Because remember that the thoughts are ego dystonic. So this ego dystonia of the thought,
they don't bother the page.
Yes, it's a big fear. So if I have a fear,
yeah,
exactly. If I have a fear, I'm not going to do the act. Okay, so that is just in OCD. Okay.
So 100%, 100% of the, I apologize, 100% of the people that have OCD, they have the disruptive thoughts. They respond 100% of the time with compulsions. Like there's no.
Almost.
Okay.
There is not another way. The compulsions to the people that suffer OCD, the compulsion is like the quickly solution, but it's not the compulsion doesn't solve the problem. Create more problems. Why? Because create more thoughts, create more fears, create more anxiety, create more depression. It's not the compulsion is not the problem. The compulsion is the trick. The compulsion is the big problem.
And the problem, I mean, it would be a dream if they were able to do the compulsion and then stop. The problem is that it creates a visual cycle that they do the compulsion and then they start again. So in a way, they get trapped within themselves. You know, in a way, they get sort of like frozen on time. Like that's like the main drastic impairment of that. And it doesn't depend whether they're by themselves or they're in a big crowd. They just get stuck within this.
Yes, it's like being in a jail, but in your mind. Your mind, in your brain, it's like being in a jail. It's that. It's a book of Jeffrey Swartz's Brain Lock is a title. That is what happened with OCD sufferers. It's like brain lock. Okay, it's like suffering your own mind, suffering with your own thoughts, suffering with your own head. That is a part of the problem. So ERP, yes, ERP helps you to create another way to respond to your thoughts, respond to the present, respond to your future, respond to the world. Okay, that is the point in ERP.
And at the biological level, it makes perfect sense why the brain lock is happening. Like, they have the disruptive thoughts that causes them stress. They cause the action to reduce the stress. Causing the action in a way increases a little bit of the pleasure of getting rid of. So having that pleasure, and pleasure probably is not the best word, but having that small release of stress makes them sort of addictive into keep wanting to have the release of the stress. And at the serotonin level, when you look at the circuits, when you look at the patterns where you work, whether it's the limbic system, whether it's the cortical systems, it is definitely a brain lock with biological. So I'm wondering if a person washing their hands gets in the brain lock of checking the sink if there's no water, the person leaves by themselves, the person lives by himself, herself, there's no one else in the apartment, they can be stuck there for hours. Like
exactly.
Like, I'm sure people have told you in the...
Yes, exactly. And that is one of the points. That's why we recommend medication versus ERP. In some case, both. In some case, just ERP. Depends on each patient. Depends on each client. Okay.
So for this,
yes. The combination in some case, and in other case, just ERP.
So when you read at the stats and they say that Zoloft works in 50% of the people very well, and on 70% of the people, sort of, that 30% that get no benefits from Zoloft or any antidepressants, they will get a benefit with ERP and with your treatment, because you're also doing what Zoloft is supposed to do, rearranging the circuits. But maybe because it is actually they actually putting cognitive effort and they putting a lot of working into it. The response might not be immediate, but it will have more durability.
Exactly. I agree with you absolutely.
And have you have any patients that have told you, thank you so much, psychologist, Psychologist Ibarra, I don't need, I'm gonna make a choice, I'm gonna stop taking Zoloft because I think with ERP is enough?
Many of them after the treatment and in the treatment stop the medication with the psychiatrist and don't need the medication.
And there's never sort of like a dramatic, like you get a call from the psychiatrist saying, oh, I lost a patient because of you, or...
some cases, some patients.
Okay. Well, but the idea is for the well-being, not having people addicted to the medications. A final question, I just thought about it. Can you be addicted to ERP? Can you be addicted to, not addicted is not the word. Can you be dependent on ERP for the rest of your life?
No, because ERP is a technique, ERP is a tool, and we show how ERP works, and combined with meditation and mindfulness techniques help to be in the present, not in the past, nor in the future, always in the present. So that change, putting on these tools in the mind of the client to life after ERP, or sometimes in some case ERP as part of your life, but not creating an addict or a dependency in ERP. It's a tool. Okay, so we show that in the client.
Thank you so much, Psychologist Alejandro, for this second week of the Ibarra Exchange. We definitely need to continue on this controversial topic, and very, very important, because there's a lot to discuss. Thank you very much.
Thank you, Luigi. Bye-bye.